All right. Once again, welcome to our webinar this evening. As I mentioned before, Dr. Emily Kirshner will be presenting Moving from Reproductive Coercion to Reproductive Justice. Dr. Emily Kirshner is a family medicine faculty attending physician at Penn Medicine Lancaster General Health. She joined the LGH Family Medicine Residency faculty in October 2020. She's a graduate of Bryn Mawr College, the Lewis Katz School of Medicine at Temple University, where she earned both her medical degree and her master's degree in urban bioethics. Her interests in medicine include maternal child health, chronic condition care, and family planning. She is an LGBTQI affirming physician and includes anti-racism work and health at every size principles in her clinical care and teaching. And she believes that healthcare is a human right. So with that, please join me in welcoming Dr. Emily Kirshner. And Dr. Kirshner, the floor is yours.
Thank you so much, everyone, for having me and for tuning in. It's always exciting to talk about reproductive justice with like-minded clinicians, and I'm familiar with the Implicit Network's work. I'm proud to work in a clinic that participates in interconception care, and I think we'll have a lot of discussion tonight. I'm going to ask your permission as I share my screen, and I feel confident, calm, cool, and collected. Still a few years into this pandemic, and I'm still feeling frightened every time we do this. And of course, I clicked the share button instead of the slideshow button. I do that every time. So as Maha said, we're going to be talking about the legacy and history of reproductive oppression and reproductive coercion tonight, as well as reproductive justice. I'd first, in a moment, I'm going to ask us to just start with introductions, so we hear a little bit about who else is here and kind of where we're coming from geographically and sort of our clinical identity or any identity you'd like to share. We'll start with that identity, the definitions of reproductive justice and that historical component of reproductive oppression and coercion, and then move on to what I hope is the bulk of our presentation, really looking at ways that we can embed reproductive justice into our clinical practices. I hope to leave time for questions and debriefing and some discussion, as well as some extended resources for anyone who'd like to learn more. So if you do have a question, raise your hand or shout it out. And if it's not a great time, I'll make sure that I'm writing it down. You can also add it in the Zoom chat and we'll try to get to it at the end. So I'm going to take us off screen sharing briefly. See, this is me practicing, just so we can all unmute ourselves in a timely fashion and share anything that you'd like to share as an introduction.
Go ahead, Dr. Radcliffe.
Well, good evening, folks. My name is Steve Ratcliffe. I had the pleasure and honor of helping to set up this network some, goodness, 17 years ago, something like that. I'm really delighted to be here. I work in a federally qualified health center here in Lancaster, PA.
Thank you. And I guess I can go ahead and introduce myself. My name is Maha Shafqat. I'm the Implicit Network Manager, and I am located in Lancaster, Pennsylvania. I'm going to go in the order of my screen. So Rachel, did you want to go next?
Sure. Hi, everyone. My name is Rachel Eng. I'm one of the facilitators of the Minnesota Implicit program. We're currently working with one clinic and onboarding 3 more. And I'm here with my colleague, Darisha.
Thank you. And Darisha, did you want to introduce yourself?
Hello, I am Darisha Vaughn from Asset She Her Hers. I'm the planning and research coordinator over at Asset, and will also be helping with the Implicit Network and the work we're doing here in Minnesota.
Thank you. Anna? Oh, Anna might be traveling. Yes. Swati?
Hi everyone, I'm Swathi. I'm an MPH student, but I'm interning with the Implicit Network. So I'm the maternal health educational outreach content creator this semester.
Thank you. Mario?
Hi, good evening, everybody. Mario DeMarco. I'm at the University of Pennsylvania. I've also been interning with the Implicit Network for a long, long time and help lead our Pennsylvania Department of Health grant.
Thank you. Amy?
Hi, I'm Amy Smith. I've been working in the Implicit Network for, I don't know, 13, 14 years. I am the clinical director for maternal health for the Institute for Family Health in Mid-Hudson and New York City. We're a very large, federally qualified health center.
Thank you. And then I know Scott mentioned that he's on the floor, so he can't speak right now, but he is also one of our family medicine physicians at the University of Rochester.
Okay.
And Carolyn?
Hi, I'm Carolyn. I'm the project coordinator here in Western PA, based in Pittsburgh. Been with the Implicit Network now for 10 months. And I'm really excited to hear this conversation. I love reproductive health is my jam, so.
Thanks, Carolyn. Right, I think for now, that is it.
I think so too. Oh, I'm sorry, I shared the wrong part. We practiced this, Maha, and I'm still screwing up. So there's.
Oh, good.
All right. So as we're defining reproductive justice, it's the idea to it's the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we do have in safe and sustainable communities. This term, this concept of reproductive justice is created in the 1990s by a collective of Black women and women of color who they were headed to Cairo for an international conference, and they had been, I'll say, let down. They had been not seeing everything that they needed to see by the women's movements of the time in terms of reproductive rights and reproductive access, didn't recognize everything that they needed as women of color and that their communities needed. And so they sat down and said, what we need is something more than that. The idea that this is a human right, this is based just like our legacy of United Nations International Bill of Human Rights. This is a human right to have control and bodily autonomy, to choose when and how I'm going to have children and the kind of birth that I want to have, to not have children and determine how I want to prevent pregnancy or end a pregnancy, and to create the family that I want to have in a safe community with resources, free from violence from other individuals and from the government. And when we talk about the concept of reproductive justice, it is I kind of emphasize it's rights-based, not just about choice. So we sometimes hear about pro-choice and anti-choice in relation to the anti-abortion movement. And some of these activists recognize that choice or the choice to have an abortion might be meaningless if the access to good health insurance is not existent. The wait for the clinic is too long. If there's not a bus line in my community to get me to the clinic, if formula is on a national shortage and very expensive, right? So this is not just a choice-based concept. And this goes beyond abortion. You heard me talk about many other parts of what reproductive justice entails. And they also identified that if this sounds great to you, don't just talk the talk with us, you got to walk the walk. So what's required to achieve reproductive justice is analyzing power systems and intersecting power structures, addressing intersecting oppressions, really centering the most marginalized who are most affected by reproductive oppression and reproductive coercion. And there's no way that we're going to achieve reproductive justice without joining together across issues and across identities. And so what you've kind of heard me just talk about is the concept of intersectionality, which may be familiar for some of you. It's a concept introduced in the late 80s that's by a feminist legal scholar, Kimberly Crenshaw. And this is an analytical framework that looks at our interconnected social and political identities, as well as interconnected power structures and systems of oppression. So thinking things like race, class, our gender identity, our disability are all working together, and the structures that have power over us and oppress us are also working together. Things like white supremacy, things like the prison industrial complex, things like the carceral system. These power structures are embedded and interconnected in more powerful ways. Going back to the idea of reproductive justice, we need to be aware of this and working to understand and disempower these structures and understand our identities to have a shot at achieving reproductive justice. This image comes from the Repeal Hide Art Project. The artist Jay Smith created the Repeal Hide Art Project probably in the 2000s. And they're also a Bryn Mawr alum, so I'm taking some Bryn Mawr credit that I knew them way back when. I think for many people on the call who are implicitors and come from a family of medicine background, that this image will speak to you, that the ideas of reproductive justice are really broad and interwoven. So when I'm supporting teen parents and imagining justice for immigrants and hoping for paid family leave, all of these parts are working to create really a just world for that I want to live in, that I want my patients and community to live into. So we're going to move now into this historical context of reproductive oppression and coercion. The next few slides, I would say, are probably the heaviest parts of the presentation. So if you need to take a little bit of a moment or a break, I invite you to do that as it feels right. And I'd like to move into this part of the presentation by acknowledging that the United States is built on legacies of colonialism, slavery, and genocide. And by extension, our health system is built on the same legacies. So on the left is an image of J. Marion Sims, Dr. Sims, sometimes called the father of American gynecology or gynecology, who achieved notoriety, fame, for learning fistula operations and perfecting that operation. Through decades of advocacy and research, largely by women of color, we've learned that his work was done on enslaved women and girls who were not able to give informed consent and who were not given anesthesia for their roles in his research. So his legacy and his fame should be, and it has been questioned only very recently. And we are only just beginning to restore the dignity and the names of the people who he enacted this medical torture on. Some of their names are Lucy, Anarcha, and Betsy. And there's a statue that's been erected for them in Montgomery, Alabama. So I use this example of really acknowledging that reproductive oppression and reproductive coercion have been tools of legacy, tools for colonialism, slavery, and genocide in our country. And they're tools of control and subjugation. So reproductive oppression is the control and exploitation of women and girls and other gender oppressed people through their bodies, their sexuality, their labor and reproduction. And the concept of reproductive coercion is a kind of intimate partner violence where someone or some people are exerting power and control over someone's reproductive health choices or bodily autonomy. So we talked a little bit about the legacy of oppression and coercion in American slavery, chattel slavery, which moves into the Reconstruction period after the Civil War, and then legalized apartheid throughout America, which continues in legacies of policing and our carceral system today. And I'm going to be jumping a little bit historically, but after the Civil War, thinking about the end of the 19th century into the 20th century, the eugenics science, eugenics movement is growing in power and popularity in the United States and the Americas. And so pseudoscience is being developed for white supremacy, this understanding. Not only can we use science to define that the white race is superior, but we can also take population measures to subjugate and control people who are undesirable, whether that's due to their race, their religion, their ethnic background, or their sort of intellectual disabilities, their criminal history, their sort of social identity. This directly leads into sterilization laws, which begin occurring in the early 1900s in a number of American states. And there's a famous Supreme Court case called Buck v. Bell that reaches the Supreme Court in 1927. And the Supreme Court uses 3 generations of women to say that some of these undesirable traits are hereditary, and that that there is precedent for states to be able to involuntarily and forcibly sterilize people. Early, the involuntary sterilization really focuses on men. So men who are criminals, poor men, also people who would have been labeled kind of mental defectives as a term of the time, people with intellectual disability or mental illness. Later, into the 20s, 30s, and beyond, we see sterilization really used to target women, not just women who are engaged in the criminal carceral system, women who are sex workers, women with intellectual disability, but also moving on to other people that the state decides should not be reproducing. Who is this? This is largely women of color, Indigenous women, and poor women. We know as well, there's this legacy in the 20th century of the Tuskegee syphilis experiment, where people Black men without informed consent are infected with syphilis and not treated even far after the cure and treatment for syphilis is known, alongside our mistreatment of Indigenous peoples in this country, including sterilizations of Native American women and girls in the 60s and 70s. It's not really known how many people have been affected. There's an estimate in the 70s that about 25%, a quarter of living Native American women and girls had been involuntarily sterilized. In the middle part of the 20th century, one of the ways that we are able to practice contraception and practice the medical care that we all practice here today is done upon Puerto Rican women, poor women who were not able to give informed consent to participate in the trial for the early contraceptive pill. Of course, this contraceptive pill has much, much higher levels of hormones that are known to be safe today. So a number of women had pretty devastating side effects and died actually in these trials. So I'm using these examples to highlight a number of examples of reproductive oppression and coercion that are built into our history and our medical history in particular. I think that some of the worst examples of this are truly the involuntary sterilization. On the left are sisters Minnie Lee and Mary Alice Ralph, who were involuntarily sterilized in the 1970s at age 12 and age 14. Their story is captured in this the novel Take My Hand. And the state of Alabama, which authorized and paid for this operation, has not acknowledged their wrongdoing in this way. Some states have begun to acknowledge wrongdoing. Some states have begun to offer some reparations for this practice. Many and most have not. And I may hear the pushback of, well, okay, the 70s was a long time ago. Some of us can remember the 70s. Even Dr. Radcliffe on this call, I think, can remember the 70s, depending on what activities he was doing in the 70s. But this practice is still ongoing. This is an image of one of the California women's prisons in a documentary called Belly of the Beast. And the California women's prison system we have uncovered forced sterilizations in their carceral system, and the most recent one occurred in 2010. So I'm stealing from Faulkner here to say the past is never dead. It's not even past. That I could stay here with many more examples of the ways in which we have failed and continue to fail women, girls, and other gender minorities in this country with reproductive oppression and coercion. And I think that's why we're here tonight. Many of us have identified this as an issue in our country and in our practice and in our careers, and we're here because we're in positions of power and want to work to address it. And so I thank you for being here, and I thank you for your attention and your contributions as we really work to undo some of the wrongs of the past and work towards preventing them in the future. So for the remainder of our time, I'd like to look at how we are practicing sexual and reproductive health care. And I'm highlighting a couple of these questions because I have a couple suggestions, I have a couple answers, but I am by no means the only authority and only thinker in this topic. So thinking, and I'm excited about your answers, where else in our practices can we reduce and eliminate reproductive oppression? Where can we foreground reproductive justice? And which groups of people might we be leaving out who are giving justice to some and not to others? So a couple ways that I've definitely thought of this and have tried to expand my practice is the practice of sex education, that I'm discussing all kinds of sex with everyone, that I'm discussing not just how to have safe sex, but discussing consent and safe relationships early on in my well child care and adolescent care, how I'm providing contraception counseling, trying to include sex positivity and sex neutrality rather than the kind of fear and shame I had been beaten with as a younger person, particularly in how I'm talking about sexually transmitted infections, how I'm providing pregnancy options counseling and decision-making, knowing that abortion care is a part of reproductive care and sexual health care, and being there to support my patients who need who need abortion or need adoption referrals, as well as giving equitable care to young people and older adults who need sexual and reproductive health care throughout their lifespans. Okay. So turning some attention to contraceptive counseling frameworks, there are a number of frameworks out there, and some come into style, come into vogue, and then fall out of vogue. So I'll highlight a couple popular strategies. The idea of a consumer-driven approach. So you hand them a menu, you hand them a handout, someone comes in and says, I want the depot. Okay, you get the depot. Which may really empower patient autonomy, but can be limiting in that it is still helpful to make sure patients have accurate information about side effects, have accurate information about other questions they might have, and make sure they're really choosing the right contraceptive method for them. I think we've moved away, hopefully, from directive counseling, that paternal idea of I give the pill out and you're getting the pill, or you've had 4 kids, so you should have a tubal ligation. But I think it still emerges a little bit of because of your BMI, or because of this risk factor, or because of this, I really think you should do this or not this. So we're trying to move away from directive and paternalistic counseling. Sort of the more popular and evidence-based frameworks that I see are called the CDC's Reproductive Life Plan, which is you can find questionnaires over there, and some EMRs apparently have this already built in, mine does not, but it's asking individuals to plan when they would like to have children, under what circumstances they would like to have children, when they want to have their children, how they want to space them. I think this is great for Emily Kirchner in the 2nd year of med school, who was, kind of regimented and planned and had it ideal. But we know that people's reproductive lives and lives in general are complex and change and go through different periods. So this may be a little more the complexity, I think, of people's lived experiences can be challenging for this model. The one key question asks us to ask our patients, would you like to become pregnant in the next year? And then direct our counseling towards preconception counseling, or if it's important to them to prevent a pregnancy, towards contraception. And then another framework is the path questions. Do you think you'd like to have children or more children at some point? When would that be? And how important is you to prevent pregnancy? Some people would say until that time, or how important is it today for you? So that can kind of direct you of what next steps in counseling you might provide. I'd like to highlight some questions about LARC first and tiered effectiveness counseling. So LARC, long-acting reversible contraception, includes the IUDs as well as the Nexplanon, the tornogestral arm implant, which are long-acting, so depending on the method, last years, and are highly effective methods of contraception, but are reversible as well, unlike a permanent sterilization method like a tubal ligation or vasectomy. So in the early 2000s, LARC use is actually relatively low. And why is this? It's kind of multifactorial. The Dicon shield is still in people's rearview mirror. There's the cost of the device and the insertion is relatively high. There's some questions about availability and provider training. And so there's some large studies that emerge in the 2000s that look at what we can do to increase this highly effective birth control. And they do promote tiered effectiveness counseling. They say there's evidence to say if you're promoting these as the most effective birth control choices, people will choose them. And because of these large studies, medical practice evolves to prioritize LARC methods. And I graduated medical school in 2017, so I am relatively young in my clinical practice, and I can absolutely say I was taught both preclinical and clinical to promote LARC first contraception, and I even got this a little bit in residency as well. So there is a concern that tiered effectiveness counseling or LARC first counseling may be a form of coercion or contraceptive coercion. Because if a clinician is encouraging LARC as the #1 choice or the best choice, perhaps we are teaching other choices as less good or worse. There's definitely been evidence that LARC has been promoted preferentially to women of color, low-income women, younger people, and people who use drugs. And when we think about that legacy of involuntary sterilization and who the state says should not be having children or more children, there is a little bit of an overlap here of whose reproduction should we control and why. And because there's a provider locus of control for LARC, because they're very effective birth control methods, and because they last for years, there's a real concern that if someone says, I'd like to have a family, or I want this out of me, and if provider refuses, I've certainly known providers who decline or refuse to remove someone's LARC, that we're not allowing someone's autonomous control over their childbearing, or really over their body if there's a device in their body that we refuse to remove. So the steps that I try to follow, and this is one strategy for it, once you've initiated your conversation about contraception, using whatever method sort of works for you, really obtaining what the patient's preferences are. So then you can highlight every method's characteristics with their preferences, making sure you have relevant medical history, and you can facilitate the decision for them so you can start a method. I tend to use RHAP, the Reproductive Health Access Project's handout. This is their 2022 update, I believe. Excuse me. And they have this handout in multiple languages. So I have it in every clinic room that I use, so I can whip it out no matter when the birth control conversation comes out, and we can talk about it together, or I can hand it to someone if they want to do some home research. So one of the phrases I use is, what else is important to you about birth control or the birth control that you use today? Sometimes I have to do a little bit of prompting because people are not expecting me to ask them what matters to them always. And so things that might matter beyond just efficacy, beyond that tiered efficacy, that how effective a method is the most important thing. But what else? How a method is taken, how often it is taken, the timing of the efficacy. So does it act very quickly? Does it take time to reach effectiveness? Will it affect my period? Do I get to control it, or does the doctor have to do it? Will anyone else know that I'm using this? How much will it cost? Will it affect my sex life? Will it affect how I have sex? Will it be permanent or affect my fertility in the future? And at what point in time will it affect my fertility? Right. So I think we've all known or been a person in graduate school who, the moment graduate school is over, it is time to have a baby. And so knowing when your fertility might return or ovulation might return might be a big factor for someone. I have yet to have someone come to me and say that they want to start a method because they want to decrease their cancer risk, but it could be out there, right? That there are other non-contraceptive benefits to some contraceptive methods, like managing dysmenorrhea, managing PCOS. And so some people may have a preference for a method because of other considerations in their life. And this is exhaustive, and you'll be doing 3-hour contraceptive counseling at every appointment. So I tend to ask what else is important. And then depending on which methods are becoming more important or less important for a person, making sure that I'm clarifying, is it important to you to have a period every month? Would spotting be a problem for you? And kind of moving methods up or down for what a person might want to choose. I think many of us have experienced frustration and moral distress when what a patient says, I don't want to be pregnant right now, it would be bad for me to be pregnant right now, and then make a decision like, but I don't want to, or I'm not ready to start birth control now. And that feels like that there's a conflict between what they're saying and what they're doing. And patients are allowed to have that conflict. And one of the through some of my abortion training and through pregnancy decision counseling, I'll highlight one of the resources, one of the lectures that I've come back to time and time again, who's really helped me understand that my investment in patients and my investment in the choices they're making for themselves really comes from my compassion for the kind of work that I'm doing. But my investment in their life and their patient is very different than my investment in their decision. So coming to believe that each patient has the answer and there's not information I have about their choices that they don't have, and that I'm there to provide support regardless of their decision, and provide information so they can make the best decision for themselves is really my role. The pregnancy is not always a negative outcome for an unplanned or pregnancy, and that can feel, I think, a little foreign to some of us, or not feel correct to some of us. And when someone has pregnancy ambivalence, this idea that if it happens, it happens, it would be okay if it happens, I encourage us also to explore what makes someone feel that way. I think it can be really helpful to have curiosity about these parts of our patients' lives. A couple months ago, a resident asked me to follow up on a patient who was having some ambivalence about pregnancy or about their contraceptive choice. And I started to explore what was going on. And the patient said, I've never had a baby with someone when dad was available. She had some children with someone who had been incarcerated. And she said, I really want the experience of him getting to be there when the baby is growing up and me being able to be there with him raising our child. And I was not expecting that answer. And that was not what my priority was going into the room. And I was not expecting that answer from the patient. So it really made me step back and see how I could support their pregnancy timing and what else would be important to help them have a healthy pregnancy when they were ready for it. And I think we can also sort of adapt some of our counseling and methods to someone who is ambivalent about their pregnancy decision making. And so I'll highlight that in the slides to come. So thinking about longer IUD strings, so a patient can self-remove an IUD, and really expanding what we're typically offering in terms of pain medicines, anxiolytics, or referrals for insertions under anesthesia. So someone who might want an IUD but is concerned about these other parts of the IUD process can still have one. Considering subcutaneous depo for home or self-administration. I have not checked all of your Medicaid formularies, but I know Pennsylvania has subcutaneous depo on its Medicaid formulary. Making sure that patients know that when you insert a LARC, it can be removed on demand. It does not have to come out in 12 years. And walking the walk, talking the talk, that you practice that. Making sure you have familiarity with non-prescription methods and non-hormonal methods, because these may be important for people. Remove office visit barriers wherever possible. incorporating emergency contraception and advanced provision of emergency contraception, which might be helpful for, I'm not sure if I want a pregnancy, but I'm not sure if I do want a pregnancy, and then an unprotected intercourse occurs and you say, I know that I'd like to use EC today. This is not the right month. This is not the right partner. Also thinking about counseling for advanced provision of medication abortion, just normalizing that abortion is part of the sexual and reproductive health care, and making sure patients know that you're a safe person to talk to if they need that care. Also how we're providing our reproductive care, like speculum care without stirrups, allowing a patient to insert their speculum, and thinking about really our language and scripting. So I'm moving beyond some of these other strategies, but I've found and have in some of the research that trauma-informed care in pelvic care can be really, really critical. Are folks using emergency contraception as part of their contraceptive practice? I'm trying to look in the, I'm seeing some blank looks, so I'm going to keep moving. Yeah. So emergency contraception is contraception that prevents pregnancy after unprotected intercourse. It is not the same as medication abortion, and it's not effective after implantation. So we should consider this in people who have had unprotected intercourse within 5 days of unprotected intercourse. And because this can be an unexpected event, talking about it as you're doing your contraceptive counseling can be really helpful. So people have this available if they need it. There are several options. So the IUDs, both copper and the 52 milligram, like levonorgestrel IUDs like Liletta and Mirena. Oral olipristal is Ella, and oral progestin. So this is the plan B or the next choice. There's also the USP method, which is taking combination birth control pills at certain doses to for emergency contraception. And if you Google USP method, there's a number of combinations based on your brand of pill, making sure you have the right kind of estrogen and progesterone dosing and how many pills you need to take. Olipristal is a selective progesterone receptor modulator. I'm trying to make sperm happen, SPRM, but no one seems to be picking up on that. Levonorgestrel is a progestone, and both of these work by inhibiting and delaying ovulation and interrupting the follicular rupture development process. IUDs are thought to work for emergency contraception kind of through their impairment of like how sperm work and maybe endometrial receptivity. The IUD is the most effective form of emergency contraception, followed by Ella, followed by progestin. I will emphasize that there is some effect on the body size for both forms of oral levonorgestrel, with a cutoff of about a BMI of 35 for Ella and about 26 for progesterone, which is pretty low. So the other part is that if someone has already ovulated or even has started to have their LH surge, which will then begin their ovulation, there's evidence that levonorgestrel EC does not work as well. So we're promoting reproductive justice. If this is the right method for someone for EC, still offer it. But if efficacy is important, the levonorgestrel is the least effective. So the IUD has to be inserted in the same process as if you're using it for non-emergency contraception, and it is effective for up to 5 days after unprotected intercourse. Ella, is also effective for up to 5 days after unprotected intercourse, and progesterone pills are effective for 72 hours and work better the more urgently you take them. So another reason for advanced provision. Ella requires a prescription, and some insurances will cover it. In Pennsylvania, Medicaid will not cover it. And it's not available at many pharmacies for same-day use. So if someone has a need for same-day Ella, calling around is going to be key. Progestin pills are available over the counter, regardless of age or gender. They are sometimes behind a counter or sometimes in one of those like locked plastic boxes on the pharmacy shelf. So encouraging people to ask for it. The pharmacy cannot tell you you can't have it because of your age or because of your gender presentation. Most insurances will cover progestin, only EC. If you don't use your insurance, it is probably going to cost $40, $50. I have some patients who have wanted an IUD for EC, but are concerned about it showing up on insurance. And I would just encourage everyone to reach out to their local FQHCs or Planned Parenthoods for sliding scale and same day availability for IUDs. Not all of our clinics can accommodate a same day procedure. For the oral ECs, you can anticipate some nausea or vomiting, maybe some menstrual irregularity. Repeated use of EC is not harmful. It does not affect if there is a pregnancy. If the EC was ineffective, it doesn't affect the developing fetus. I would tell someone that if they haven't had a typical period in about 3 weeks after using it, they should take a home pregnancy test. And depending on those results and their preferences, either follow up for pregnancy decision-making and whatever they need from that. EC is not as effective as most contraceptive methods, but there's not a downside to offering it as a contraceptive choice for someone who might have ambivalence about pregnancy. So that people can use EC if it feels right for them as a method of kind of on-demand contraception. I advise advanced provision of olipristal or levonorgestrel so people can have it when they need it. Know that because olipristal is that sperm and it interacts with progesterone, you need to wait 5 days before you initiate another form of hormone-containing contraception. There is some evidence in animal studies that olipristal will be excreted in breast milk. For our breastfeeding patients or chest feeding patients, pumping and discarding the milk for 24 hours is currently recommended. I give multiple refills on prescriptions, and I advise you to check in with your local pharmacies about Ella and olipristal because it was not available in my local pharmacies until I called our hospital convenience pharmacy and got it in stock. I got into a fight with someone at Rite Aid or CVS who told me that this medicine did not exist. So, and they kept trying to recommend Plan B. You might need to be a little bit of a trailblazer. I also encourage you to be prepared to offer pregnancy decision counseling that's patient-centered. So everyone has the choice to continue their pregnancy and parent or make an adoption plan or end their pregnancy. Abortion is still safe and legal in, I think, all of the states that are represented here tonight. I know there have been a couple other additions to the call. And self-managed abortion is safe and effective. So having letting your patients know you can be approached about these issues is really critical. Knowing your local clinics, abortion funds, and being aware of where patients may be receiving deceptive or coercive information from anti-abortion centers is critical. And knowing resources for adoption, highlighting agencies that include queer families and single parents. Not all adoption agencies do. So since we do have about 15 minutes, I want to make sure that we have some time to discuss and ask questions together. I know Maha will share the slides tonight, so I'm just going to go through a few of my resources so you'll know what's coming. And if there isn't something that you would like to know more about, let me know so I can make sure that that's included in the email out. So a couple more resources on reproductive justice. I'd highlight the Innovating Education, which is a program through UCSF. Their self-guided course is really great. And the two books on the side by Dorothy Roberts, Killing the Black Body, and Medical Apartheid by Harriet Washington are kind of like the texts about this, about these concepts and about sort of the legacies of reproductive oppression and coercion in our country. Highlighting, this was just perfectly timed. I didn't mean for this to be during Lent, but Faith Aloud is a counseling organization that helps people process their pregnancy decision-making. And they lead a 40 Days of Prayer for Reproductive Justice, kind of in response to the anti-abortion movement's 40 Days for Life. And so one of their statements from day 3 was, today we pray for our children and grandchildren, that they will always know the power of making their own decisions, which I think is kind of a beautiful meditation. I highlight for pregnancy options counseling, there's a couple different choices. This pregnancy options counseling that's also through Innovating Education has been really helpful to me. I've come back to the videos and the courses and the reflections several times. I can't recommend that enough. There's a couple helpful points about emergency contraception if you'd like to start practicing it. Both the CDC MEC app and the point of care contraception app, probably the most common ones that we're using, are really, really great and include EC. And then the Reproductive Health Access Project has 2 guides about using EC that are really great, available in multiple languages. I really bring up the Reproductive Health Access Project. You can join a cluster if you're not already, based on either your region or your professional identity. So they have emergency medicine, they have internal medicine, they also have APCs, so you can join and work across, work with other colleagues. And then Feminist Midwife, you can follow on social media, sign up for their newsletter. Really great scripting for sexual and reproductive care. I've learned a lot about, they have a great script for providing speculum care without stirrups, delivering STI results that I've really benefited from. So those are a couple of my resources that will come away in your follow-up. So I'm going to take us off screen share and open it up for anyone who has some questions, who has some discussion points. Thank you for your attention, and the floor is yours.
Thank you so much, Emily. Does anybody have any follow-up questions?
Thank you very much. That was very thorough. My question is regarding education. Do you give this lecture for your residents on a regular basis? Do they get any extra training in reproductive justice?
That's a great question. So I think my short answer is sort of. I think that in graduate medical education, we can be doing a much better job at incorporating these like legacies of oppression and coercion. I was a history undergrad major, so I'm kind of a geek for this, like talking about this and thinking about this and incorporating it. When I give lectures on like contraception and emergency contraception and pregnancy decision making, I use that reproductive justice slide from with the image of the person and like what else is involved in reproductive justice. I'm practicing in Lancaster, Pennsylvania. We have some non-prescribers of contraception in our residency. And so I'm not afraid of initiating this conflict, but I also want people to be able to hear what I'm saying and not get bogged down in this girl's trying to tell us to send people for abortion care. I want us to be able to meet together and say, this is reproductive justice is not just about abortion, access and abortion care. It's about so many more of these things that we can hopefully agree on. That was me talking a lot and not giving you an answer. So not as much as they should is my answer, I think.
Got it.
I guess I'll ask a follow-up question from that then. Like, what is the best way for us to incorporate it into the residencies? Any suggestions?
So I think medical schools are getting better at their what's probably called like a social justice curriculum, because I had learned about the Tuskegee study in college and into medical school. These things were brought up, and when I was getting some of this information repeated in residency, attendings were surprised that we had already had this earlier in our kit, because for them it had not been included in their earlier medical education. So I think medical schools are getting better at this curriculum, and I'm seeing that sometimes in our applicants of what people are interested in when they come to residency. But then I think it's like, I don't know what you guys think. I think it's where the metal meets where the pedal, like where the tire meets the road is what I'm trying to say. So you might have this here, but then when you walk into the room with the patient and they're not doing what you think they should, and there's this, that I think is harder to take a step back and say, why do I want this? Like, why can't I allow this patient to have their choice or have their autonomy here? What do you guys think about where you're practicing?
I'm not a physician, so I can't answer that one.
We have a fairly integrated teaching. I work with Linda Prine. So it's very integrated in the downstate sites, and we try and copy what they're doing in the upstate sites. And with intermittent success, I would say. But then every once in a while, I'll have an interaction with a resident where I'm surprised by how they're presenting choices to patients. And I'm like, didn't they learn this? Did we teach it right? How do we teach it better? So I'm always looking for new ways to do it.
Yeah, and I also have another question. So we do have some sites where it's not the interconception care questions are not always just physician driven. You know, nurses can also play some role in that as well. So for such sites where nurses are playing a bigger role in providing this interconception care, are there any suggestions for how they can, help with this or engage in such conversations? Rachel, do you have any thoughts, or do you have any additional question in regards to that?
Yeah. Or like a warm handoff around like implicit screener around family planning, if it's positive. Yeah, what that warm handoff might be with an MA or a nurse, and then a doctor who might be providing more of the intervention.
I think we've come into not our screener is given by like the rooming staff, and then the physician goes in, and when there is one or more young person in the room, it can be challenging to fill out the screener. Sometimes it's not done at the beginning, at the end, it can feel like an add-on. I don't think I have a good answer, just acknowledging that it's challenging. And I think that maybe that's a possible, I don't know, intervention or research follow-up of asking rooming staff, nursing staff what they need or what they want to know about the process. Are they feeling like that just offering the screener and encouraging someone to fill it out is enough? Do they want more information about how to give some minimal counseling or information about contraceptive choices? I feel like I would need to ask the roomers what's going on. And I also sometimes wonder if they're in Lancaster, I think there's sometimes people have been with our practice a long time. There's generations of people who've been with our practice. So sometimes the rapport, camaraderie of our nurse who's been with us for a long time, knowing mom, knowing grandma, and then I come into the room and the laughter stops. I think I'm a hoot and a half, but so is there like a rapport thing that would happen if, Anna is giving some of this advice or some of this handoff versus like Emily Kirchner walks in and it's like all serious, so I don't know, is my long answer to your simple question.
Yeah, thank you. That's helpful. And I think part of it is just increasing buy-in at the sites for implicit as a program and as a model, so that the nurses or MAs just know more about kind of the why around the different elements of implicit. But yeah, I'm curious now to kind of talk more with our clinics about information needs.
Yeah. And I mean, we've talked today about ways in which contraception and sterilization have been forced on people without their consent or desire. And we also know that like there has been a lack of access or equitable access for control over contraception, abortion care for people who want to be able to have more autonomy over their reproduction and the ways that they plan their families. So I think it can, we have not talked about that as much, but it can swing both ways in that making sure that we're offering contraception as a part of, I mean, part of implicit is this idea that can really help empower your health, the health of your family, and your goals around when you want to have children too. So I acknowledge that it goes both, can go in both directions. I'm reading out loud for anyone who isn't in the chat. We, from Mario, we just planned a PDSA to stock bedsider.org patient contraceptive choice guides to help make contraception interventions easier. The dilemma, do we advance in the wrong direction or wait to encourage contraception counseling using better frameworks? Yeah. I think bedsiders, so bedsider.org, I've not looked at their handout lately, but I know that their website also is a pretty like non-directive. So you highlight the method, they're all sort of there in images, and they're kind of a efficacy, but other information, side effects, who else it might be good for. Also in the way that the RHAP guide has tried to move away from pros and cons, but sort of this is the information you need to know about these methods, because what might be a pro for one person is a con for another. And I do think that I find that people do need some type of hard copy or follow-up resource to help make their choice, especially if they're not ready in the visit, because there's just so much information. People have usually gotten some information from TikTok or their friend on the way in, and they need a little bit of time to make that choice. Maybe that's the answer. Implicit should be on TikTok.
Well, working on Facebook and Instagram right now. So maybe TikTok is next. All right. Well, we are close to end time. Any final questions, comments?
Thanks for answering that question, Emily. Sorry, I'm transitioning to work on the labor floor tonight, but the bedsider.org website is really good with those patient-centered sort of parameters, but their materials that are printed are very much tiered. They literally have like that diagram with like 100 stick figures and how many will get pregnant at the end of the year. And so, that it doesn't really match what I think that their website sort of offers, but the website is sort of hard to do in 1 minute.
Yeah.
Awesome. Well, I want to thank Emily for all this hard work that you put in and giving us your time this evening.
Thank you.
Really appreciated this presentation, and appreciate everybody here on this Zoom. So thank you so much. And with that, I'm going to let you go back to your families. Have a wonderful evening, everyone. Thank you so much again, Emily.
Thank you. And I'm ending. You can hear the meowing in the background. It's dinner time at our house. So apologies for that noise. I might rather hear the labor and delivery background in Mario's than this cat meowing, but that's what we have tonight. Sorry, guys.
All right. Take care.